everyone, and welcome to Eggs, Ethics, and Everything in Between. My name is Abigail, and I am conducting the interview for this episode today. I am a senior at Northern Arizona University, and I'm majoring in biology with a minor in Spanish. My future goals are to work in healthcare administration, and today I'm interviewing Jane. Hi, thank you for joining us. I am joined here by Jane. Jane is a nurse practitioner in a fertility clinic. Welcome in, Jane. And can you tell me a little bit about yourself and your experience?
Sure. I'm a women's health nurse practitioner, and I earned my degree at Arizona State University. And I've been a nurse practitioner since 2014 and worked in infertility clinics for the last 19 years. My role is primarily managing the clinic and also third-party reproduction.
Very nice. Well, thank
Mhm.
you for joining us.
Thanks for having me.
I wanted to take this opportunity to introduce some key terms that our audience may not know. They may know, and they just need a refresher on. I'm introducing these all in the context of our class, which is the Introduction to Bioethics. First and foremost, assisted reproductive technology is a field within reproductive healthcare that deals with alternative methods for reproduction. Reproductive healthcare is a field of healthcare that focuses on male and female reproductive structures. For the sake of this conversation, we're focused on female reproductive healthcare. Bioethics is defined as a more philosophical approach to life and ethics concerning personhood, public policy, and the direction of science. IVF, which is also known as in vitro fertilization, is the fertilization of an egg outside the body to then be implanted in the uterus. The first question that I wanted to ask was, in your opinion, what does bioethics mean in the context of reproductive health care and why is it important?
I think it's important because it is often controversial. Um, I think people have different thoughts about what is right and what is wrong. And then there lately has been a lot of political diversity over what is right and what is wrong. And so right now it's a very hot topic. And it is a challenge to be able to work through it and understand kind of what all of the different schools of thought are, and being able to accommodate patients when there is just a lot of controversy surrounding their treatment cycle.
Definitely, that's super important. And I feel like that does actually flow into an idea that is really focused on in our class, which are all of the principles of bioethics. They're very similar
Mhm.
to those fields of thought that you bring up. In bioethics, in our class context, we talked about beneficence, non-maleficence, justice, and autonomy. And they all go hand in hand, but a lot of people tend to shift their focus towards one or the other, even if they don't realize that
Mhm.
they're doing it. Like ethics is, in a way, sometimes a very subconscious sort of a field. So that definitely relates. The way that we define beneficence is seeking to do the most good. Non-maleficence is
Mhm.
seeking to avoid harm. Autonomy is, just as a direct quote, seeking to satisfy the wishes of the affected individual as long as they understand the decision being made and its consequences in the context of their own life. Justice is seeking to provide equal treatment to all individuals regardless of merit, socioeconomic standing, age, gender, religion, etc. For you specifically, which of these do you observe as the primary principle in the ethics aspect of assisted reproductive technology? And which do you feel is the most important?
First of all, I wanted to address your comment about sometimes it being a subconscious part of who we are as practitioners. And when I was in nursing school many, many years ago, the thought was we should bring it to the forefront of our mind and be aware of it instead of being it subconscious. And even if it means identifying where our biases are, that is more important to know where they are so that we're not transferring them to our patients. So I've really kind of made an effort over the years to do that. I think that I feel most in line with autonomy because I love patient-centered healthcare. One of my favorite things to do is to educate patients about their own health, about infertility, about treatment options, risks and benefits. And the goal is to empower them to be able to make their own decisions. So I would say that is almost always my goal when I'm interacting with patients. Sometimes patients are not comfortable making their own decisions, and so they're leaning more towards, the provider's clinical recommendation, and that's okay too.
I think it's especially important to bring up that sometimes patients don't know exactly what they're looking for and they don't have all the answers to make a choice that they consider to be informed. So that's
Mhm.
super vital. And I agree completely with your perspective on making sure ethics is a conscious effort. A lot of the time, when it's in the back of your mind and it's something that you just kind of don't pay attention to on your day to day, it doesn't have enough attention. And that's a really big part of why we chose this topic for our podcast is if you're not in the midst of the field, it's not something that you really get to think about or confront like within yourself. Like, what are my implicit biases? What do I think ethically until you are in the field for whatever reason, whether you're a patient or you're a provider. Thank you again for joining us because that's something that we want to see become more widespread.
I think that any time that a provider is uncomfortable, he or she needs to ask themselves why. Why are we uncomfortable in this situation? And it's not up to us to impose our views on the patient, but we do want to make sure we're delivering respectful care.
How have you seen bioethics change over time in the field?
I would say that most recently, the change to push pregnancy termination to the states created quite an uproar, and particularly here in Arizona, because my understanding is that there were two laws that were on the books and they were not aligned. And so that created a little bit of controversy. It was difficult for providers to prescribe medication. And in infertility, we are not terminating pregnancies, but sometimes we have a patient who's had what we call a missed AB, so retained products of conception that are not viable. And it was a real problem to get those medications. So that was a little bit uncomfortable for providers because we're trying to deliver care and there was an obstacle or two there. And then there have been a group of people or a person who will sometimes spread propaganda out by the door, like Bible verses or things like that, to either intimidate the clinic or the patients who enter. So it's fine to have whatever opinion that they have, but I think to intimidate people like that is not appropriate. Also, there's been a lot of discussion about transgender, and you wouldn't think that it would make its way to infertility, but it does. So there's a constant struggle there for those patients to help them build their family, but there's also a feeling of whether or not that is the right thing to do. So then that brings us back to beneficence. So who is my patient? Is it the man or the woman's sitting in front of me, or is it the child born into this relationship? So those are the things that I'm seeing more frequently now than were ever discussed, a dozen years ago.
Yeah, definitely. I mean, a lot of these things we wouldn't have even thought about several years ago. And it seems
Mm.
like they definitely have come to the forefront a lot more, and adapting as a whole field is such a tremendous feat. It's a completely different world we live in than it was 20 years ago already, you know?
Mhm.
So thank you for your perspective. The next question is super similar, and it really piggybacks off of what you just said. I am curious how you think cultural, religious, or societal values influence ethical decision making in reproductive health care. Should they influence ethical decision making in reproductive health care? And again, that is super related to what you just said from a provider and also from a patient perspective. How do you
Mhm.
feel like those really influence the decisions, and should they?
I would say I have opinions about all of them, but it doesn't change the way I manage their care. In particular, I remember one patient many years ago, and she said that she was Greek Orthodox for her religion. And she called me one day on the phone sobbing because she was using an egg donor to build her family, and her priest said that her children would not be Greek Orthodox because of the way she initiated her pregnancy and built her family. I felt so terrible for her that someone else, granted, this gentleman had a status high in her church, but he's still human nonetheless, and that he would relay that message to her like that. There's certainly nothing I could do about that. I just kind of told her what I just told you. If her religion is important to her, then she should continue it, and but also add perspective and support her. I mean, she called me. She didn't reach out to anybody else in the church that I know of. She called her provider. So those are tough scenarios to be in. Or patients who discard embryos. Should that be allowed? Should it be allowed for normal and abnormal? That those things aren't up for me to say. But sometimes it hurts my heart when I see some decisions made, or if a perfectly healthy embryo is discarded because it's a certain gender. Those are tough things to see. And I'm not saying that every day is a test of my bioethics. It certainly is not, but that's what the discussion is. And so that's how all of these things are coming to mind. But they don't keep me from assisting patients with assisted reproductive technology, third-party reproduction, gender identity. It's just all part of it. I have perspective and know where my own bioethics lie, but it's not for me to impose it on somebody else.
Definitely relates back to the value that you put on autonomy. And despite having your own opinions on things, like you still come in every day and you are coming in from the perspective of, I'm going to provide the best care to everyone, no matter
Mhm.
who it is, no matter what they're facing. It may be a different solution for someone versus another person, but you're going to approach it from the perspective of, I'm going to do my best today and I'm going to give you my best today, no matter what form that comes in.
Mhm.
Very similar to something that you just brought up. What is your take on the practice of pre-implantation genetic diagnoses? And for people who are listening, that is defined as testing one or two cells when an embryo is at the 8 to 16 cell stage for certain defects, and if clear, then moving forward. I know that this brings up a lot of questions about creating an ideal race or something like designer babies, which is a term that has kind of come to light recently. How much
Mhm.
should you be able to change, if at all, is changing something for a medical reason, like avoiding a certain disease that may run in your family, more ethical than choosing something based off of gender or like eye color, if that was even a thing. What is your take
Mm.
on that, all in all?
So that kind of technology does exist. I think it's called CRISPR technology, but it's not really implemented in reproductive endocrinology clinics. We do have PGT testing, and the most common one is a karyotype. So it confirms if an embryo has a normal chromosome complement, and we call that a euploid embryo. So no extra chromosomes, no missing chromosomes. So if we have a euploid embryo that is identified before we transfer it into the patient, then our pregnancy rates go up and our miscarriage rates go down. And so that can be very helpful in, moving this family building process along. Another type of PGT is PGTM, where we're looking for a certain gene. So the genetic parents complete a genetic carrier screen, and there is a test to see if they're a carrier for a disease. And the number of diseases that are included in the panel can change depending on which genetics lab you use or which panel you use. So if we find that the patient, the female patient, or the provider of egg and the provider of sperm are a carrier for the same condition, then their children have a much higher rate of having that condition than the general population. And so in that scenario, we can test the embryos to see if they are unaffected, a carrier, or affected. And then in that sense, we could reduce the transmission of that disease, or in this case, add it to this family. I guess I would say I like that technology, for lack of a better word. If we can have healthy babies, that's great. But you're right about it being kind of a slippery slope. If we can, change the gene for Huntington's disease, should we also be changing the genes for hair color, eye color, skin color, right-handed, athletic, body type? Like, where does it end? And so that's where the whole designer baby thing comes into play.
I think it's so fascinating because my degree is in biology, and
Hmm.
it's really interesting, like actually hearing the application of those things like in your workplace. I
Hmm.
read about them all the time. I read about karyotypes and I read about pedigrees, and you see how certain traits are transmitted, if they're transmitted as an autosomal recessive, if they're transmitted as a sex-linked trait. So it's really interesting actually hearing that being applied in everyday context for some people in their job. Do you think all patients receive equal treatment in reproductive health care around the world, or are there barriers that raise ethical concerns? How much do you actually hear from being in the United States how other countries are doing things?
I'm fairly certain that reproductive health care is different all across the world. Um, I have shipped embryos to Ukraine right before the war started because I had a couple who found a gestational carrier in that country, and they were successful. And the reason they chose Ukraine is because it was more cost effective. I have also seen patients go to the Czech Republic for their IVF cycles and come back to the US with a complication called ovarian hyperstimulation syndrome. Physicians, when they see patients like that in the ER, if they're not 100% sure what they're looking at, they might not quite know how to treat her. And so that was a situation where the patient did her egg retrieval in the Czech Republic and then came back to Arizona and then came to the practice where I was working at the time and asked us to treat her. So we had to hospitalize her and treat her. They went to the Czech Republic because it was less expensive to bank their embryos. And then I have some international patients here who will go to their country of origin, either in South America or India, and um, and complete some components of their art cycles there. But the FDA gets involved because, you can't just ship tissue across country borders without going through a process. It's more like fourth party reproduction or fifth party reproduction. There's just a lot of components there.
Interestingly, there are countries like Italy or Austria, Germany as well, where IVF is actually illegal to varying degrees, which I did not know
Mhm.
about, with a number of reasons for their decisions. Sometimes it's concerns regarding waste, like we talked about embryonic waste, the
Mhm.
status of embryos, and also, interestingly, exploitation of women and disrupting long-standing family structures were a couple to name. Earlier, we brought up religion, and that's
Mhm.
actually a big part of where those come from. Exploitation of women is mostly actually in relation to donating versus doing like IVF treatments, but more so egg and sperm donors, more so egg donors, because it seemed like exploitation of women was actually the main concern versus exploitation of men. But
Mhm.
that was something that was a concern for some of these countries that have like some legal barriers to certain care. The long-standing family structures was interesting to me as well, just because that was very religion based. In
Mhm.
their mind, a lot of that actually has to do with a predominantly Catholic population over in Europe. And we already spoke about this too, but like to what extent should religion influence one's ethics? Where is the practice? If it's somewhere that has a lot of the same people, is it more ethical or should it be standardized?
Yeah, that's an interesting perspective. So diversity versus uniformity of the population, does that make a difference? In the Catholic religion, men are not allowed to ejaculate outside the woman's body. Yet I have patients who describe themselves as participating in the Catholic faith, and some of them have an issue with it, and some of them are okay to bend that rule. I have patients who practice the Jewish faith, and they are not available on some days, or the man cannot be with the woman on certain days. And so we do our best to work around those times when managing their cycles, or they can't drive a car, or they can't talk on the phone or use the computer. That just goes to show you how much religion plays a role in politics, I guess.
It can be related to religion, but it could also not be related to religion. Some countries also ban gamete donations or IVF treatment for people who are in the LGBTQ plus community. You briefly
Mhm.
touched on the transgender community earlier, which is a part of that, but it is also because it could complicate the biological family dynamic. Do you feel like in that case it could be an ethical rationale, or do you not really see the place for banning that for those communities?
In one sense, gay men are banned from being sperm donors in the United States. Not outwardly, but in order to pass the FDA screening, there's a questionnaire and it's about 37 questions. And it identifies high risk population of people that are prone to infectious disease. And one of them is gay men. And so one of the questions on there says, have you had sex with another man? And if the answer is yes, then they cannot be sperm donor. And it's meant to protect the recipient. It's not because there's any concern about having gay gametes out there for patients to match with to build their family. So that part's understandable. They can use a gestational carrier because that's a directed sperm donation. So they generally have an egg donor and then they use their own sperm to fertilize the eggs, and then the embryos are transferred to the third party. So the FDA is always trying to make sure that their third party is being protected from the risk of being the recipient of infectious disease. right? So it's all about protecting her. So if the gay men answer yes to that question, then I go to the gestational carrier and I say, okay, they tested negative for infectious disease, including HIV. And are you okay with this risk? And if she says yes, then the FDA is okay with that too. Then we can proceed.
Interesting. I feel like that's something like you would not know if you've never gone through the process. Given that the umbrella topic for this conversation is focused on reproductive healthcare ethics, there is a strong relationship with the idea of treatment versus prevention. So I'm curious if you feel like IVF should be considered essential in a circumstance where resources are limited. Would it be ever ethical to deny care in assisted reproductive technology? And if so, at what time?
When we had that stay in place order in Arizona in 2020, we had 5 weeks where we couldn't proceed with any kind of elective surgery. And so we basically shut down. However, patients who had already starting to stimulate their ovaries, we had to complete their egg retrievals because that was going to jeopardize the patient's health if we didn't do that. So we did complete some. I just assume what I heard was correct about the resources. The PPE, okay, was hard to come by, and so we couldn't use or get PPE. It is elective, it's not mandated. It is sometimes prohibitive because of the cost and the benefits, which is probably another branch of bioethics. I mean, I think just patients kind of picked up where they left off. In 5 weeks isn't going to be seriously detrimental even to patients who have severe diminished ovarian reserve. Looking back on it, I think, we got some things wrong, but at the time, you didn't know.
That's an important perspective, I think, to take into consideration. And you're completely right about it being another kind of field of bioethics. That really falls under the umbrella of justice, which is seeking to provide equal treatment to all individuals, regardless of merit, socioeconomic standing, age, gender, religion, etc. The next question I have is if you could, what suggestions do you have to improve the field of assisted reproductive technology, and how do they relate to the bioethical principles that you feel align most with the field?
The first thing that comes to mind is that I often see couples wait until later in life to build their family. And then it becomes an all-consuming issue for them. And it's hard to watch them struggle. And I'm not 100% sure women understand that as we mature, the quantity and quality of our eggs diminishes. And I feel like that should be part of education in school or women's health, in a scenario where you're seeing women for their health maintenance. And it might be a challenging thing to discuss with someone about their fertility because you don't want to put pressure where it didn't exist before. But I do think it's part of the decision making. In 2006, the FDA approved vitrification for egg freezing. So now there's an opportunity for patients to freeze eggs. It's an option if patients need it, but it's also not a sure thing. So I think it's important for women to know that. So I guess that's autonomy.
I mean, I agree completely. For me, it's something that because I was interested in this field, I knew about. But for people who don't follow it as closely, like they may have no idea, and then it almost feels like you're right, like putting pressure where it wasn't before, but also like this new sort of like looming feeling of, I should have thought
Mhm.
about this sooner. But how do you think about it sooner when you don't know it exists? So I think that that's really valuable and super important to bring up and bring into light. Because bioethics is such a changing field, what is your advice to providers or future providers in the field?
I find my role in reproductive endocrinology to be very rewarding. There's also a lot of opportunity for provider burnout, also celebration. And I think we have to take care of ourselves better. We have to be centered. We're no good to anybody else unless we take care of ourselves. And so, in order to bring our A game all the time, we should support each other. And sometimes that doesn't happen. And it seems kind of corny to say it out loud, but I think that's the advice I would give.
Corny or not, I think it is really important. So I appreciate that perspective a lot. I think community is a very strong tool, and we don't see the
Mhm.
value in it quite enough. Thank you so much for joining us. I really appreciate your time and your insight. It was exceptional.
No, thanks. You're very welcome.
It is time for the No Eggs Attached segment for this episode of Eggs, Ethics, and Everything in Between, where we discuss everything from IVF to bioethics. I conducted this interview on October 24th with a nurse practitioner named Jane. The main themes in this interview were focused around autonomy, bioethics in a changing world, and what equity of treatment means in the field of infertility treatments and assisted reproductive technology. Jane brought some exceptional insight from her time as a nurse practitioner and leaves advice for patients and providers alike. Providers should always protect their mental health and physical well being because they should be the best versions of themselves for both their benefit and those they care for. Patients should not shy away from educating themselves on their biology and what impacts things like time can have on any future family planning. Finally, the most important part of this conversation is that bioethics should be a conscious conversation that we have with ourselves and with others. Enabling this mindset will allow us to confront our biases and promote a social system in which ethics is at the forefront of decision making. Our podcast aims to improve the general public's awareness and knowledge of the ethical situations that exist in the field of female reproductive health care, and this episode has certainly achieved that goal. We want to give a final thank you to Jane for joining us and sharing her perspectives, and we also want to thank you for joining us for this episode. Stay tuned for more episodes of Eggs, Ethics, and Everything in Between, where reproductive choices meet ethical questions.